So our talk today is about recognizing and supporting care for people with long COVID. And at ECHO, we've actually been working on long COVID discussions and the research for nearly 2 years now. As it's evolving, sharing information. A lot of the previous information was actually about the pathophysiology of long COVID, the details of how what findings you would see as the disease progressed after the acute phase. And so today we're going to actually shift gears a bit and focus more on the management, because we know there's so much pathology of long COVID, but the reality is that people living with it and it's affecting their lives and their functions. And today we're going to try to concentrate on that. And that's why we're joined by Megha, an occupational therapist, psychotherapist at CAMH, and Jennifer Hulme, who's an emerged doc with great expertise on long COVID, but also lived experience. And she'll speak from both perspectives on how we can support management for patients with it. So as mentioned, you can actually view the previous details, which actually give you more information of what to expect from the imaging studies or the blood work you might do for patients with long COVID. And the links are there for you for the YouTube video, as well as the slide deck in detail to go through. So these are just the disclosure. There's nothing in conflict with this presentation today for me. And for Megha as well, no disclosures or conflicts. And finally, for Jennifer, the disclosures are there and also no conflicts. And she'll be speaking, as she mentioned, also from a lived experience perspective. We built up this talk actually on learning on the mental health applications of long COVID that Sanjeev and Kathy Sheehan has also put together. Rena Besser, our CAMH librarian, always gives us lots of great details. We'll share them here. And from the UK, Dr. Tricia Greenhalgh, who's a family doctor, does amazing research on long COVID. And I suggest you follow her for also more detailed information. So CAMH is supported and the ministry supports the ECHO talks, and there's no disclosures related to that. Wherever possible, we'll talk about the evidence basis, and we'll also talk about what's indirect evidence and what's consensus evidence or best practice at this point, recognizing for something new like the management of long COVID, you're not going to have the same degree of evidence basis. There'll be more translating information from related disorders and what's actually appropriate from the risk-benefit perspective for your patients. Our goals today will be talking about recognizing the breadth and severity of long COVID symptoms, describing the assessment and management of long COVID, and identifying approaches to prevention of long COVID. So first of all, what's in a name? There have been so many different names for this disorder. Long COVID is what all of us tend to call it. The WHO definition calls it post-COVID-19 condition, but there are other variations you'll see in different jurisdictions like Ontario, and the CDC and all the rest have different labels on this. And so recognizing there be some changes and gaps and overlaps with these diagnoses when they happen. You see there in gray long hauler COVID-19, and this is just a reminder that as clinicians, and this is very different from what we do as clinicians or those with lived experience, we know we want to destigmatize any disease for patients and not only see them through the lens of the disease, which is why there's a movement in general across disease states to talk about a person with an illness as opposed to labeling the person through the illness. But somebody with the disorder obviously can speak about it in a way that feels comfortable to them. And so you'll see some variation in how that label is used through this presentation today as well. So how many people does long COVID affect? And I've summarized a lot of data here for you, just to keep it one quick place. You remember that graph from the top left? At the beginning of the pandemic in Ontario, when we were trying to figure out what to expect in the waves of acute illness and delayed illness and mental health, one thing that was missing entirely was the long COVID or the post-acute symptoms of the disease itself. And I've tried to depict that with that pink graph there, showing you it's not just one acute phase that goes away and comes down, but an accumulation of patients with chronic illness that continue. There is some improvements, but definitely there is a larger volume of patients who will at any one point have long COVID in the end than just acute COVID. And so the most recent analysis, and this is from the Nature paper looking at long COVID just 2 weeks ago, summarizes of people who are not hospitalized for COVID, who are at home, about 10 to 30% of them will end up having long COVID after the fact. And 50 to 70%, so a majority of patients who are hospitalized will have long COVID as well. And if you're vaccinated, at least 10 to 12%. So 1 in 10 people at a minimum will have long COVID after their infection, even though they've had their vaccines. There is some evidence suggesting more vaccines may reduce the risk a little bit more, but it's not, to me, you can pretend you won't get just because you're vaccinated. Globally, though, these estimates are always underestimates here, because we know that since January in Ontario of last year, we haven't had much testing in comparison to what we had before per capita. And so we're always underestimating the amount of COVID that's happening here. Other parts of the world have not been able to test the majority of their population as they were sick as well. So globally, it's estimated right now, we're probably facing about 65 million people or more who have long COVID. That's assuming a 10% long COVID rate, so a very low rate. In Canada, looking at the numbers of COVID cases that we've confirmed, and our estimate in Canada is about nearly 15% of patients will have long COVID. That's our specific national estimate. So just under 660,000 Canadians will have had long COVID. Ontario, that translates to an estimate of around 230,000. Now, some of those will have gotten better over time, and we'll go through what to expect there as well, but also recognizing there's an underestimate happening here in terms of the volume of infections. A recent national study in Scandinavia showed that 90% of the people living with long COVID today had initially mild long COVID. And that's simply a volume effect because the majority of people are not hospitalized now. That doesn't mean they don't end up having consequences after the fact. The majority of those were between the ages of 36 and 50. That's prime working years. And we'll come to the implications of that in a moment. Women are at least 22% more likely to develop long COVID. And there's a couple of hypotheses for these, including the autoimmune pathway. Long COVID is a number of different ways in which it causes harm and damage. Autoimmunity is one of them. And we've known for a long time that women can have 3 to 5 times the rate of certain autoimmune diseases than men as well. Children also develop long COVID. The large systematic review meta-analysis pegs that number at about 25%. One of the studies that actually was the most encouraging suggested that kids who had mild COVID that never had to be hospitalized had as little as 5%. That's still 1 in 20 children who would have long COVID. And now you're recognizing the volume. Over the last winter, we've had around 70% of kids in Canada catch COVID for the first time. And so even 1 in 20 is a significant number. The Ontario Science Table estimated last fall that we would have 250,000 excess, largely primary care visits due to long COVID in Ontario per year. And that's before we even have had this winter surge. So a lot to worry about. Now, looking at the wider socioeconomic implications, there have been a lot of discussions from early last year looking at the labor market and what role long COVID could play. A U.S. analysis pegged the number at about 15% of unfilled jobs were due to long COVID. Quebec's health minister talked about 10% of the healthcare workers being off due to long COVID in that shortage they had last summer that shut down many ERs. And just a week ago, the UK Chancellor was actually begging people who were retired, who were sick after COVID to return back to work because it was actually impacting their economic growth so significantly. In particular, he said if companies can't get the staff they need, they can't grow. And the estimate due to the disability claims have gone up 70% since the pandemic began, that they're going to hit about $8.2 billion in costs within the next 5 years due to this. Now, recognizing England obviously dialed back a lot of the safety measures like masking and stuff a lot earlier than we did. So maybe we're seeing a forecast of what we might have to expect here if things don't change. So how long does long COVID last? Acute COVID is about 2 to 3 weeks on average. We don't call it this official long COVID post-acute syndrome until after you get to 3 months, which means people can have symptoms lingering on until 3 months, but we don't label it as long COVID. It doesn't mean these aren't post-COVID complications because they are. And this is why certain very serious but rarer conditions like multi-system inflammatory syndrome in children or adults, which typically happen 1 to 2 months after COVID, are not captured under the long COVID umbrella in Ontario. So if you're expecting what to see, so this is an early study, but it still holds very true. So symptoms do tend to get better over time, but it's a shallow graph improvement. You begin to tell some differences by 2 months, and that's what's useful. If you have more severe symptoms after 2 months, or if you have more numbers of new symptoms after 2 months, you're more likely to be the patient who has problems that last at least 7 months, as opposed to somebody who seems to be getting better by 2 months and therefore are less likely to have problems. So that point of inflection is useful in terms of estimating trajectory of illness for patients. But we know that more than 70% of long COVID patients had symptoms for more than 3 months, and also that 1/3 had symptoms for more than a year. So pretty significant numbers overall. So what causes long COVID? And it helps to recognize that COVID is not just a respiratory illness when you're looking at what it does to you. It's primarily a vascular endothelial disease, which affects and infects the blood vessel lining cells the most, and that's everywhere in your body that they go, and a lot of other cell types too. So the damage we see in long COVID flows from that initial damage and the type of virus and damage that COVID does. So the hypotheses about what causes long COVID are combinations of a couple of different ideas. So one is persistent SARS-2 viral reservoir. That means persistent viral fragments. And so we do have a lot of evidence showing that RNA fragments or pieces of COVID certainly persist in pretty much every type of tissue that we have, including our cartilage now, and that can be there for many, many months. Now, RNA is quite a fragile molecule, which means if you actually have persistence of fragments even 7 months later, it's unlikely that it's from the original infection, but certainly that's a thought we have. It's worth recognizing also more recently that when they actually looked at the brains of people who had severe sick COVID, but recovered from it and died for other reasons 7 months later, they found not only viral fragments in their brain 7 months later, but these fragments were able to replicate when they put them to cell culture. So this is a viable virus in their brain 7 months later in a small, severe population, but it does give us a clue that this virus is much more durable and may persist longer in the body than we would like to think. So immune dysregulation, so that could be suppression of certain cell types or any post-viral process, but also this may be related to seeing a reactivation of other dormant viruses that we may have accumulated in our life prior to this. Things like Epstein-Barr virus or human herpes virus 6 or 7, and other viruses as well. So it's recognizing there's a suppression of our immune process that may be occurring, an overactivation in inappropriate ways for autoimmune disease, for example, and also reactivation of other viruses causing inflammation too. So we also see some changes in the microbiome, the gut, the bacteria and viruses in our gut and other places. As I mentioned, the autoimmunity, we know that autoimmune disease is much more common, especially with more severe COVID, but also occurring with milder COVID. And we also see that in children in association with type 1 diabetes at about double the rate that we saw post-flu, for example. We see microvascular clotting. This is emerging research where it's not able to be done in regular labs, but in research labs, they can begin to see a lot of microclots in patients who have long COVID. And the dysfunctional brainstem and vagus nerve signaling that may be responsible for some of the fatigue, as well as the postural issues and orthostatic issues that we see in patients with long COVID. So very quickly, there's about 203 different symptoms of long COVID affecting all the body systems. This is a great summary graph that looks at the symptoms and the pathophysiology. So for example, in the brain, we see cognitive impairment that is actually quite significant, about half as bad as a stroke in patients who are not hospitalized for COVID even. Memory loss, ringing in the ears. We see the dysautonomia, the myalgic encephalitis or chronic fatigue syndrome overlaps happening here. We see autoimmune diseases, as mentioned, and the mast cell activation syndrome, diabetes at a higher rate, shortness of breath, and now abnormal gas exchange, and the gastrointestinal symptoms are also very common post-COVID. So we'll go through this in more detail later on, but the main thing to keep in mind is functional limitation is a key part of long COVID. And just early in January, the largest New York State insurer described what they saw in their worker populations. And they saw that of the claimants with long COVID, 18% were unable to return to work in 1 year. So nearly 1 in 5 were still not working 1 year later. Of those who did return back to work within 2 months, nearly half of them still needed ongoing medical support to be able to keep on working. And our previous studies had shown that nearly half needed to reduce work hours. The Canadian government still signals about a long-term disability of about 10% in patients who have long COVID. So it's a very significant process. So how is long COVID diagnosed? The WHO has a tentative working definition that describes having symptoms that either came from the acute infection or developed after the acute infection of COVID and lasting at least 2 months, and can be explained by other diagnoses. So you may not have a positive PCR test or rapid test, because we know a lot of people cannot get those. But if you have a likely history of exposure and you're having symptoms lasting this long, that's likely. The key part is right now it's described as a diagnosis of exclusion, meaning I cannot label it a different disease. And that's good in the sense that we don't want to overcall long COVID when we could find something that we could treat. The downside of this is actually we're going to have patients accumulating 5 or 6 different diagnoses over time. As you saw, we actually have labels for all these different things, but we won't call it long COVID. The downside is that we then don't give them the comprehensive care that we would support with long COVID. We also don't look for the next pathology we would expect to rise if we recognize it was long COVID. So we say it's your heart, but we don't think about your blood vessels, your immune system if we don't call it long COVID. And that's the downside of not having enough of an index of suspicion around long COVID. So just earlier this month, the Ministry of Health actually created the new long COVID diagnostic code, which we can begin to use. But as I mentioned, you can see why that might not be used. It'll be underestimated because people are labeling it 5 other diseases instead when they see patients. Also worth recognizing, about half patients with long COVID also do meet the criteria for ME/CFS. And so you should actually be looking for that. And the kind of things you see with that are post-exertional malaise, and we'll be talking more about that in a moment, non-restorative sleep, and also cognitive impairment and or that orthostatic intolerance. Now, ME/CFS was already seen to occur after the first SARS virus in the early 2000s. It also occurs with other viruses like EBV, Ross, River and West Nile viruses, as well as the organism that causes Q fever. So with this, I'm going to hand it over now to Jennifer to talk about the assessment and treatment of long COVID and also her personal experience with that process.
Sure, thank you, Javed. So yeah, my name is Jennifer Hulme. I recognize a lot of you actually in the chat, so it's nice to see you. I'm an emergency physician and addictions physician, but I have not been able to work full-time or even close to it since I got sick in April of last year. I documented a little bit of my experience, like pretty much only 6 weeks after getting sick, in this article in Healthy Debate, and I posted that in the chat because it does get into a little bit why women might be more affected than men with this condition. The next slide. So I'll describe first what I think you need to know. And I said, you know, like a lot of people identify as long haulers. I think I do myself, but because people have struggled so much with getting the care that they need, and even recognition just to be able to apply for disability, I think that, you know, there's like a number of steps that that we as providers need to go through in identifying the different components of long COVID so that we can help patients and really aggressively treat it to help them with their symptoms. So the first is really knowing what is post-exertional malaise, like what is this thing? It's crazy that, you know, people have been living with myalgic encephalomyelitis and these other post-viral conditions, you know, for years, but we've kind of been misdiagnosing things. So just knowing what that is and how to recognize it when people describe their symptoms. Making the diagnosis of POTS. In my case, there was a long delay of like 4 months in getting my diagnosis. For many people, that's even longer. And the nice thing about POTS is it's super treatable. Doesn't mean you're going to make 100% difference in their quality of life, but you can make a really significant difference with aggressive treatment of POTS. And there are many other forms of dysautonomia. It really affects about 80% of people with long COVID. I'm going to give a brief update on the evidence that we have to date about prevention of long COVID, just because it's going to come up again and again, especially as the prevalence of long COVID increases. The first question is going to be like, what do I do to prevent this from happening? And for people who already have long COVID, they're going to want to know what to do when they get reinfected. And then to have an approach to prescribe medications and supplements that may be helpful for your patients, because they're going to try everything, whether you know you like it or not. And it's a good idea to know what there might be some loose evidence around, and know where to refer your patients. So I know most of you are in Ontario. I personally have had a really good experience with the long COVID program at Cornerstone Physio, and I do think most people who I know who've had a positive experience are followed by them, because they really know how to support people on resting and pacing and on POTS treatment. And we can go a little bit into what that looks like. Next slide. So first, maybe I'm just going to describe my experience with long COVID to situate this discussion, because I think I've had every single long COVID, like there are 200 plus symptoms. I think I've had most of them, and they've come at different time points. I was infected by my toddler, as most of us are, at the beginning of April, and was sick for about 9 days. I worked 16 hours on day 11, because that's what we're supposed to do, right? Like day 10, you're good. And then on day 11, you go back to work. And I worked some overnight shifts that weekend, and I was tired, like I was bone tired, but like definitely not dysfunctional, not cognitively impaired. By April 11th, I was absolutely panicked, like so sick, cognitively impaired, unable to remember my address, extremely short of breath, dyspneic, dizzy, extremely fatigued, like, you know, cancer-like fatigue. And contacted everyone I could possibly contact, including like Angela Chung, Yu Chen, like just reaching out to any ID doctor I knew, like how can I prevent myself from getting worse? There were no good answers. And I was seen at the COVID clinic and had pretty typical findings, right? I had a elevated blood pressure, high heart rate. I was not formally screened for POTS as far as I know. A restrictive pattern on my PFT, still within normal limits, but definitely abnormal for me, and slightly low saturation for me. And the plan was to rest and pace and be off work. I was told to go off work 1 month at a time, but really realistically, I was probably not going to be better until 9 to 12 months later is what I was told. By the end of May, I was getting very impatient and quite deep into the literature for both ME and for long COVID. So I tried low dose naltrexone, and actually it helped a little bit. This was all through my amazing family doctor. In June, I had spoke to the trialists working on brain fog and who were trialing an SSRI. And I tried Trintellix, and also got, because this is what they were studying, of course, and I see this as a mental health group. So you'll know, like, Trintellix is thought to have maybe a bit more of cognitive benefits. So I tried it and had benefit really overnight as well. And I was quite excited by that, but I still had very severe symptoms. And then by the end of June, I was connected with the long COVID physiotherapists, and they very easily diagnosed POTS. So they'll ask most of the patients to order some kind of wearable device to follow their heart rate variability and their heart rate. But you could do this even with something like virtually with your patient if they have a pulse oximeter at home. And the way that you diagnose POTS is very simple. You have them lie down for 3 minutes and look at their heart rate every minute, and then stand up for 10 minutes and measure their heart rate for 10 minutes every minute. And if there's a sustained change, so an increase of 30 beats per minute for that orthostatic change, then this is diagnostic of POTS. And then for children and for adolescents, that change has to be 40 beats per minute. There are some blood pressure things and other things that I'll refer you to, but really this is the easy, quick diagnosis of POTS. And this mattered because, of course, you could take fluid, salt, and compression stockings to start, and a slew of medications that can make a big difference in the quality of life of people with POTS. However, by July, I had sudden sensorineural hearing loss. I already at baseline had horrific pulsatile tinnitus. And then I had this new, screaming tinnitus. ENT told me have a good life. So I advocated for myself to get into the hyperbaric chamber. And for me, it was absolutely miraculous. This was funded by OHIP because of the sensorineural hearing loss. And I got my hearing back. The tinnitus completely resolved in 4 sessions, but of course I didn't tell anyone. I went for the full 20 sessions and really had a big improvement in my brain fog and fatigue. And from there, I really declined. So I stopped. I tried to go back to work a little bit. I stopped hyperbaric and declined quite precipitously. And it was really not until sort of the late fall where I re-engaged with hyperbaric, paying out of pocket, in combination with starting a beta blocker for POTS and midodrine for POTS. And then I had this real great increase in my quality of life from those 2 interventions, I believe. And went back to work. I was able to do 4-hour shifts. And then I was reinfected 4 weeks ago. So my life has been hell. And I'm going through a lot of the same things again. So severe POTS, brain fog, cognitive impairment, and then new vertigo, which is super fun. And also very common post-COVID. So I'm slowly getting better with the help of my big team. Next slide. How do we stop long COVID before it even starts? There's really very little evidence, but what we do know is the following. There are 2 trials that Catherine Wu sort of alludes to she's been covering long COVID for The Atlantic really over the last 3 years and doing a great job of it. So one is a study that showed a 42% relative decrease in the incidence of long COVID in those who received metformin. So you bet your bottom dollar I started metformin when I was reinfected a couple of weeks ago. The second piece is a trial of, this is not a randomized control trial, it's a retrospective analysis of electronic medical records of about 56,000 high-risk patients. So these are veterans. This is a veteran study. And of those who received Paxlovid, 26%, they were 26% less likely to report long COVID symptoms at 3 months. So this is not enough, to definitively say Paxlovid prevents long COVID. But again, you bet for someone who has lived experience with this, I definitely took Paxlovid when I got reinfected. And I do think it's probably made a difference, but it's hard to know. Next slide. So what does make a difference? What do we know with confidence? The first thing is to actively screen, like we talked about for POTS. This is an excellent article that really summarizes what we know so far about postural orthostatic tachycardia syndrome. And it's a very reassuring article in the sense that it's like, listen, this is great for primary care. Everyone can do this. You can do this. And just because, even if you don't have experience yet, prescribing beta blockers or Vabradine or Midodrine, well, you're going to, because you're going to see 5 to 10% of your patient population is going to have some form of dysautonomia, unfortunately, with this sort of mass disabling event. And this is a great resource to use to guide your practice. Next slide. I find the Canadian Cardiovascular Position Statement on POTS is slightly easier and also extremely encouraging in terms of the level of evidence that exists for each type of treatment, including each type of medical treatment. Again, what I would highlight is don't wait until people are bedbound. If they are, and you have to eat a disgusting amount of salt. So if you're eating 10 grams of salt, your 3 liters of water a day, your compression stockings to your waist, and people are still dizzy, still having brain fog, fatigue, anything like that, start medications. It can make a really big difference. Start with either a beta blocker or Vabradine and add Midodrine as a pressor to help with if the blood pressure isn't too high to begin with. Next slide. What other evidence-based treatments exist? I mean, what we know from the ME literature is definitely that self-management in terms of resting and pacing is the mainstay of treatment. If people are like me, they will not want to rest and pace. They will want to push until they collapse for weeks at a time. This is a terrible cycle that most people with some form of post-exertional malaise and myalgic encephalomyelitis suffer from. So I've just put one app in this slide, but there are many that are emerging that can be really helpful for people to monitor their symptoms and manage their own symptoms. Again, I've really benefited from advice from the long COVID physio, specifically at Cornerstone. I don't know of any others that exist, but I'm sure they do. And they would help me. So they would say, okay, every hour for 3 minutes, you got to lie down and perfuse your brain. So I would be in clinic, I would lie down, I'd go back, I'd lie down. And this is the type of advice that can be super helpful as they monitor your heart rate variability to get a sense of where you're at. There is a new study that got a lot of press that deserves some discussion. So the study was just of 12 patients. These are the numbers we're dealing with long COVID, which trialed guanfacine and in combination with NAC, and found that 8 out of 12 got really significant benefit in terms of brain fog and cognition. And, guanfacine is not a medication that most of us are familiar with, right? It's an ADHD medication, but it's also an oral antihypertensive agent. And how does it work? The principal mechanism of action is that it stimulates the central alpha-2 adrenergic receptors. By stimulating these receptors, it seems to reduce sympathetic drive, right? Sympathetic nerve impulses, which is why, especially when people just start the medication, there's a lot of dizziness, hypotension, and also fatigue. But these side effects do tend to go away after a couple of weeks. And the way that it works in terms of ADHD is that it enhances the effectiveness of the signal of the pyramidal neurons in the prefrontal cortex, which improves working memory and attention. So it's kind of 2 for 1 for a long COVID patient, right? Because we have all of these, many of the symptoms are driven by dysautonomia, but also you have this, the brain fog and the cognition issues. I will say, just from the people who have tried it and that I've met on Twitter Spaces, it seems extremely promising. So is it worth trialing with your patients if they're open to it? Absolutely. The other piece is, of course, there's really strong evidence for an SSRI for any mood changes post-COVID, which is extremely high prevalence. But, again, recognizing that neuroinflammation is the driver of a lot of these symptoms, it seems that the SSRIs are working through inflammatory pathways, right? As sigma-1 receptor agonists, and they decrease IL-6, which is a cytokine that's really felt to drive a lot of long COVID symptoms. Really worth trying an SSRI. And dysautonomia, we talked about the strong role of medications if conservative management isn't enough. Next slide. I think it's important to be aware of the other stuff that people are taking, especially the stuff that may require a prescription from a provider. It's pretty well established that microclotting and endothelial dysfunction may be contributing to symptoms. And certainly I have recently started a statin which was prescribed, but I was previously taking sort of the natural equivalent, like red yeast rice. Many people have mast cell activation syndrome, which seems triggered by their COVID infection, and really benefit from an H1 and H2 blocker, which can be prescribed and can be used in combination with quercetin, which is an over-the-counter supplement. I think anyone with long COVID is already on niacin, B complex, coenzyme Q10, maybe D-ribose, and this is all sort of driven by this, the idea of mitochondrial dysfunction and what we know from the ME literature. And then again, most of us are on NAC. What we know from the ME literature is there's some evidence for low-dose naltrexone and low-dose aripiprazole, and the combination of the two may be better than the two of them alone. I personally got some benefit initially, and that benefit seemed to wane. And that was, Dr. Chung also mentioned that she's seeing this in her patients, that they get a bit better for a few weeks and then doesn't make a big difference. Who knows? We need the trials to know to know better, but it's definitely worth trialing with people. The last thing I'll say about treatment is that many people with long COVID are trying intermittent and long-term fasting. I do fast for 3 to 4 days at a time. It is so difficult. But the idea is really to promote autophagy and mitophagy, right? So cell turnover. Either those cells are damaged from previous COVID infection, we know that there's mitochondrial dysfunction at play, but we can't know for sure until, the trials are done. But I do see a lot of people anecdotally getting incremental benefit from prolonged fasting, and it's something that certainly they can be connected with patient groups to consider. Next slide. I want to just leave you with the idea that this is a bad condition. People are at really high risk of suicide. And the best thing that we can do from my perspective is show solidarity with people and help them with their symptoms as best we can. So if they have insomnia, treat their insomnia. If they have headaches, treat their headaches. Certainly, you could try something like amitriptyline QHS or gabapentin QHS, which is something you might use based on the TBI literature. Magnesium for sleep may also help their headaches. And just recognizing again that this profound neuroinflammation means that people are at very high risk of suicide. Many people anecdotally in the sort of long COVID community say that the gaslighting from their physicians is really what drives them to want to end their lives. So it's really important to just show solidarity with people and help them with their disability as well. So there's an increasing number of people applying for medically assisted death who have run out of money because they're unable to work with long COVID. So it's our role to also help people with their disability applications and advocate for financial support. I'm happy to take questions at the end, and I'll have a look at the chat.
Great, thank you so much. And actually, I hand it over now. You're recognizing so clearly the need for hope in managing a chronic illness like this. I'll hand it over to Megha, who can talk about how people recover their function in their lives.
Yeah, we heard a lot of great stuff regarding a prevalence assessment diagnosis from a physician lens, as well as from someone with lived experience. And I'll be chatting a little bit more from a non-pharmacological lens on ways you can support your clients living with long COVID. So really, as Jennifer had already mentioned, many clients possibly living with long COVID or living with long COVID report feeling like their symptoms are not taken seriously. And they might not even be aware of what they're experiencing is connected to COVID. So really approaching with empathy, listening, and validation. As mentioned earlier, women do have a higher prevalence of long COVID, and really keeping in mind that there has been historically an invalidation of medical symptoms for women. And so that's something else to keep in mind. Next slide. With respect to physical symptoms, again, this was chatted about, overexertion can increase the worsening of long COVID symptoms. And so really using a cautious approach to physical activity while monitoring for post-exertional malaise. So some immediate, symptoms that you can look for are breathlessness, dizziness, nausea. Some more short-term things keep you joint and muscle pain, brain fog, headaches, sleep disturbances. And, again, as Jennifer was mentioning, for somebody who is used to doing a lot, this is going to be hard. And, sometimes just reminding folks that there can be often this push of wanting to do a lot, and then there can be this crash and an increase of symptoms. And then it kind of can lead to frustration, increased mental health issues. And then again, symptoms will subside, and then there's a push and crash again. So sometimes even just educating folks that starting off slow can be helpful more long-term for them and can actually help them function a little bit better. Next slide. So managing fatigue after COVID-19, and Javed, feel free to sort of click through all of them. I won't go through all of them in detail, but what I will say is that really the idea is balancing rest, routine, and really supporting clients with getting back to things that they do enjoy is so important. Because again, the fatigue can last months to a year or more for some individuals. So again, if fatigue is improving, you know, again, encouraging them to try a small amount of activity that feels manageable and start to incorporate their routine again. But again, thinking about how to do this in a way that's safe. For work, considering phased return to work, and I'll chat a little bit more about that. One thing to keep in mind as well is that stress and worry do use energy. And so really supporting your clients with being kind to themselves when they're not able to do what they normally can do. And I'll chat a bit more about the mental health piece as well. Next slide. So some strategies to conserve energy after COVID-19 and with long COVID. And again, I think Jennifer really spoke well to this idea around pacing, as well as planning and prioritizing. So I'll give some examples on the next slide. So when thinking about pacing and prioritizing, with pacing, really thinking about setting realistic goals. Considering physical, cognitive, and social activities that impact their energy levels, and seeing if there are ways to break activities into smaller tasks. And for prioritizing, it can be working with your client to say, hey, what do I need to do today? What do I want to do today? What can maybe be put off? And are there other supports that they can bring in to help them with some of their daily activities? Again, planning ahead, so noticing when energy levels are a little bit better, and it might be doing some activity then and following that by rest. It could be considering adaptive equipment depending on the symptoms, and again, considering support system. In terms of energy conservation and some ways to manage that, our body mechanics can actually make a big difference. So again, supporting someone in completing tasks without pulling, lifting, bending, reaching, for example, and really encouraging avoiding holding breath during tasks, particularly if somebody is experiencing difficulties with breathing. Next slide. With respect to managing mental health, again, this has been spoken about already, but many individuals report changes to their mental health and well-being when living with long COVID. So considering self-management techniques such as mindfulness practice, social support groups, which I believe there was a question about, and Javed, I think, will be chatting a little bit more about that in the end. And again, paced behavioral activation, so supporting and encouraging activity through pacing and doing it slowly. Similar strategies can be helpful for brain fog, and symptom journaling can be helpful, particularly also tracking for mood to screen for any comorbid mental health diagnoses. The PHQ-9 or the depression, anxiety, stress scale are some scales that you can use. And then if indicated, it could be referring someone for diagnostic clarity if that's not something that you do, and supporting them with any mental health issues. Next slide. One tracking app that individuals can use is called the COVID-19 Yorkshire Rehabilitation Scale. And this is, individuals can sort of put in their pre-COVID symptoms or pre-COVID baseline and then afterwards. And here you can they can see what's improving, if there's deterioration, if there's fluctuation in symptoms, and they can put in physical and mental health symptoms here. So that's one resource that you might be able to use. Next slide. And lastly, what I'm going to chat about is just occupational support for people living with long COVID. And Javed spoke about the difficulties already. There's an absence of clear rehab pathways. So employees are on an uncertain journey, and a lot of people are facing a lot of difficulty with having to go to work. There's no job adjustments, but as was mentioned earlier, it's that a lot of people are having symptoms that are lasting 5 to 12 weeks or longer. And so ways that you can support clients is talking to their employer about accommodations. It might be working fewer hours, working from home where possible. Really quickly, if you are supporting someone with an ODSP application, there have been some applications approved. That being said, it can be tough. Some ways to strengthen the application can be to record symptoms and how it impacts function, treatment suggestions that they have been given from their physician and what's actually been followed through on. And then some other resources that can support you in working with individuals there are COVID-19 outpatient rehab programs. I can put a link in the chat. And some family health teams do have COVID clinics. So if your client is connected to a family health team with one, that may be another resource as well.
Great, thank you. So I'll just summarize really quickly because we're coming to our time now. So recognizing prevention of long COVID is the most important thing. The measures of wearing a mask, avoiding high-risk situations or contacting it. Vaccination reduces it between 14 and 40%, so it's worthwhile getting vaccinated. And Jennifer talked about the emerging evidence around prevention with medications as well. So there's a great summary graph here from the UK looking at approaches in primary care, looking at the self-management and validation being key. The self-support tools, there's YouTube videos and a lot of self-support recommendations are summarized here, and the groups that are mentioned on social media and all the platforms now. And just a reminder there's the new NICE guidelines updated in November of last year, looking at support of long COVID as well. So I'll stop there and hand it over to Katie.